So we have another case prepared. Let's get 5 minutes on the clock, and your time starts now. All right, so we're into case time now, and again, turning this into a bit more of a case discussion than a clinical encounter. This case really is about handling uncertainty, and on questioning the patient, you're not really going to get too much more information other than kind of vague symptoms without being able to specifically hone down a diagnosis. But obviously, with those ongoing symptoms of breathlessness, shortness of breath, it would definitely warrant further investigation, preferably by ED. But again, the patient here would be Linda would be refusing to go to the ED from the previous statements. So the first thing to tackle with this kind of case is how would you actually approach Linda's reluctance to attend the emergency department. And so the first part is to acknowledge the frustrations with ED having long wait times and validating her concerns. Try and use empathetic statements like, I understand that waiting in the ED can be really challenging or frustrating, but gently explain why, in this case in particular, ED care is important given her current symptoms and the possible risks of delaying definitive diagnosis and definitive treatment. Emphasize that her health and safety is the priority for yourself and for her, and explain that in that circumstance, ED is the best equipped place to actually handle these kinds of medical situations. Surprise, surprise, she would still refuse. And so, how would you actually explain the need for ED in a way that undresses her uncertainty? Clarify that while the symptoms might not feel serious, shortness of breath and low oxygen are signs that need further evaluation. Explain that while it could be related to her asthma, there's also a possibility of more serious diagnoses such as more serious infections, pneumonias, cardiac conditions, clots in the chest, things that you can't differentiate without further investigation, but could have bigger implications in terms of her immediate and long-term health. So emphasize that delaying evaluation could potentially lead to a worse outcome, and that the ED doctors have the resources to give the most timely, safe, and effective assessment. Surprise, surprise, she still doesn't want to go. So then it's about how would you actually tackle and target a safe management plan for this condition within the constraints of what you can. So it's creating a safety plan that emphasizes monitoring of the symptoms, organizing investigations as appropriate, heavily documenting all discussions that have occurred, and encouraging the patient, even if she's declining now, to still attend the emergency department. You could encourage use of things like a pulse oximeter if she has one. You'll be amazed after the COVID era how many patients actually do have them. You can organise for a phone check-in either that evening or the next morning or in a timely manner, or a review in clinic again within 24 hours. Encourage her to have someone nearby at all times as well, so that if her condition does change or deteriorate, there's someone who's able to raise the flag, call for help, and again, get her to an appropriate setting. So again, other things that you could try and do would be to arrange a home visit from community nurse or other support service. If available, refer to an urgent care clinic, which can be appropriate for some areas, and I guess would depend on the exact setting for this. It doesn't really specify if there is one nearby, but certainly it's a bit of a buzzword that is worth throwing out in this situation. Reinforce that while the options may provide some immediate support, they're not a substitute for the ED evaluation if her symptoms worsen. And of course, what is her follow-up plan if she does continue to decline or the situation changes? So arrange that follow-up call or in-person review within 24 hours to review symptoms. Advise her to keep a phone nearby and ensure someone's available to assist her. Emphasize that if symptoms worsen or she experiences any chest pain, shortness of breath, or dizziness, altered mental state, she should call emergency services immediately, providing her with both written information and contact details for after-hours support as well. Now, we do have some comments coming in from the chat as well. We have here asthma action plan. And yes, certainly would be worth throwing in that you would be reviewing her asthma management plan, and part of that written information would best include that with her history of asthma there. There is thrown in the little bit of wheeze there. If you had delved into the history, it would have been a bit more vague and uncertain if there was any asthma there. For investigations, yes, things like a pro-BNP could be appropriate for looking into congestive cardiac failure. and urgent echo and chest x-ray, definitely very valid investigation options. You can access emergency physician via telehealth. Yes, this is a good answer. I dare say, though, that the downside to this particular case would be simply that this patient doesn't need telehealth. They need in-person investigations. They need auscultation of chest, imaging, pathology. This is something that's probably bigger than a telephone call, but I do like this option because it does also get a second medical mind listening in. And sometimes just hearing the same thing from multiple sources can be enough to convince some patients to say, actually, maybe I will go to the emergency department after all. So, yep, definitely things I think would be very good to throw in there. So, again, this case is not so much what you're answering. This case is really about displaying that you have a well-structured approach to these situations of uncertainty, which really is the bread and butter of general practice, that you are able to implement a safe and effective management plan for those patients who have that risk of deterioration, and to make sure, again, this is the last kind of safety check before you're released into the world as a fellow GP, that you're able to make sensible decisions to try and convince and redirect patients towards appropriate care. And if they still decline, as is their right, patients are allowed to make bad decisions, unfortunately sometimes, but to make sure that you actually have an approach to safety net these patients as much as possible. And I did mention it, but I want to really emphasize the importance of actually documenting these discussions and documenting your insistence the patient attend, but despite multiple attempts, the patient has declined. Very, very important. Some places you'll hear it called the care policy. Cover backside, retain employment, CARE. One way to remember it. But again, from that medical legal risk point of view, it is a very important part of this case as well. So for this, the competent candidate recognises the need for the urgent assessment, providing a clear rationale for ED referral, creating that safety plan to monitor symptoms and escalate care appropriately if the patient does refuse. The communication is with empathy, listening to the patient's concerns, addressing the uncertainty with reassurance and understanding, using clear patient-centered language to explain the risks of delaying care, applying clinical guidelines for managing respiratory distress and emphasising the importance of urgent assessment while respecting patient autonomy, and developing an alternative safety plan that balances the need for care with the patient's wishes.